Guys, my name's Chris. I'm a fifth year student, and I thought I'd go over a bit of haematology today, things that would be useful for exams that might be beneficial for you. So let's get stuck in. So this is kind of a broad list of things which I think would be good to go over for exams. It's certainly what I use to go over for finals. It is quite a long list, and haematology can be quite an overwhelming topic to get your head around. Lots of different terms, and it can be confusing. So I can't really go over all of this today because I'd be here for hours and I'm sure I'd bore you to death. So today we're just going to be focusing on the top two, so hematological malignancies, and there are a few slides at the end on anemia. I'm not going to go into it in great detail because there's quite a lot to it, but I'm just going to give you a few points that I think would be useful for the exam. So essentially what we'll cover is leukemia, myelodysplastic syndrome, myeloproliferative disorders, myeloma, lymphoma, and very briefly on anemias. So in order to understand the hematological malignancies, you kind of need to understand the cell lineage of the immune system. So all cells start off as a hematopoietic stem cell or a hemocytoblast, and then they either go down two lines, the myeloid line or the lymphoid line. So if you go down the lymphoid line, you get natural killer cells and lymphocytes. Your lymphocytes can either be T or B lymphocytes, and then your B lymphocytes go on to produce plasma cells, and it's your plasma cells in the blood what produces your antibodies. And then looking over on the other side is all your other kind of cells. So along the myeloid line are your that's where you get your platelets from, your red blood cells, your mast cells, and your myeloblasts. So all your different white blood cells, so basophils, neutrophils, eosinophils, and monocytes. I wouldn't say there's one particular way to learn this. I just think you have to sit down and kind of go over it and just hammer it home, really. So we'll start with leukemias. So what is leukemia? So leukemia is a cancer of the white blood cells. There are different ways of dividing leukemia. So you can divide it acute and chronic. So acute leukemia means that it progresses a lot more quickly and aggressively, and usually it requires immediate treatment. And it can be myeloid or lymphoid, so depending on the cells which are cancerous. And essentially it's dysregulated proliferation of white blood cells in the bone marrow. So leukemia cells proliferating in the bone marrow, they replace the normal cells and they reduce other elements of the bone marrow, causing abnormal blood counts. So because often on the blood counts, you'll see high level of white blood cells, and you might think this is a good thing, it'll help fight infection, but these are immature cancerous cells that don't function normally. So malignant cells do not function normally. So going over risk factors for leukemia. So being male, radiation, so previous radiotherapy for things like breast cancer or other malignancies, previous chemotherapy, congenital syndromes, previous myelodysplastic syndrome, which we'll get onto in a little while, and Down syndrome. They're all risk factors to be aware of. So we said we can split leukemia into acute and chronic. So acute is characterized by a proliferation of blast cells. Blast cells are just immature cells, and chronic is a proliferation of mature cells. So one's immature and one's mature. And then acute can be AML or ALL, depending on whether it's myeloid or lymphoid. And then chronic can be CML or CLL. So we'll go through each one of them in turn. Okay, so starting with AML, acute myeloid leukemia. This tends to affect older patients, mainly patients over the age of 65. It may occur as a primary disease or following a secondary transformation of a myelodysplastic syndrome. Prognosis is getting better as treatments improve. And the main thing to take home from AML is that it can be diagnosed when there are more than 20% blasts in the blood. So there are a few buzzwords to know for AML, things that words, if they come up in your exam, it's likely to be AML. Does anyone know any of these? If you pop them down in the chat or unmute yourself. Any suggestions, or are we not getting anything? Okay, that's fine. So words which are linked to AML. So here's a picture of them which might help. You can see over here, highlighted. So these are called hour rods. These hour rods are essentially crystallized granules, and they result from the abnormal fusion of the primary granules. And this is the best way to differentiate AML from ALL, because clinically they're very similar. And the other buzzword is Down syndrome. So if you see in a question that the patient has Down syndrome and it's likely to be leukemia, then AML is the most common type of blood cancer in Down syndrome. So that's AML. Moving on to ALL, there's not a huge amount to say about ALL other than the peak incidence is around 2 to 5 years old. So it's the most common childhood cancer. So if people are on placement at Alder Hey, you're likely to see quite a lot of ALL. It's got quite a good prognosis, and a lot of kids go into remission, but prognosis isn't very good in the elderly. So features of acute leukemias, they're very similar. They can present in the same way AML and ALL. Essentially, it's bone marrow failure that causes the symptoms. So bone marrow failure leads to pancytopenia. Pancytopenia just means that there are low red blood cells, low white cells, and low platelets. It's important to note that, as we said before, white blood cells might appear high when you do your blood test, but these are immature blasts and don't work functionally as mature cells. So the symptoms are derived from the pancytopenia. So if you have a low amount of red blood cells, symptoms will be pallor, lethargy, and weakness. So your typical symptoms of anemia. And if you have low functional white blood cells, then recurrent infections. And lastly, low platelets can lead to bleeding and bruising. So the best way to think about different features of leukemia is by thinking structurally about what's affected and what the outcomes will be. That's how I found it helpful. So going on next to some other features which may differentiate between the two. So AML, you can get something called leukostasis. It's more common in AML than ALL. Leukostasis, it's a medical emergency. It's where you have a rapid increased number of blasts, so immature white blood cells, and this can cause decreased tissue perfusion. It increases the blood viscosity and can predispose you to thrombosis, so things like strokes and DVTs. That can occur in both. In that picture there, you can see gingival hyperplasia. There are a few drugs that can cause it, things like cyclosporin or phenytoin, or some calcium channel blockers as well. But if it's not associated with any drugs, in exam questions, they might link it to AML. And you can also get hepatosplenomegaly. And then ALL, which is more common in kids, you can see things like bone or joint pain. There can be involvement of the testicles, so orchidomegaly. There can be mediastinal involvement, central neurosystem involvement, lymphadenopathy, which is quite common, and hepatosplenomegaly again. I didn't really go into the management of acute leukemias because I don't really think it's that relevant for exams, and certainly when you graduate as junior doctors, you won't be expected to go through the management. This is all quite complex treatment. But just for interest's sake, AML, usually patients have 3 to 4 cycles of combination chemotherapy, and you can also have stem cell transplants in select patients. And for ALL, they have induction consolidation chemotherapy. They can also have stem cell transplants in 2 years for girls and 3 years for boys to make sure you eradicate any testicular involvement. And you can also give central nervous system prophylaxis as well, so intrathecal chemotherapy. So that's a broad overview of acute leukemias. So I'll move on to chronic leukemias now. So in the same way that acute leukemias are divided into AML and ALL, chronic leukemia is divided into CML and CLL. So starting with CML, it's quite a rare cancer, not very common. The median onset, that should say 50 years old, not 50%. And you can get a blast crisis, which means that chronic leukemias can transform to acute leukemias. more commonly AML. A take-home point for CML, which could come up in exams, is 95% are Philadelphia chromosome positive. A Philadelphia chromosome is a translocation of chromosomes 9 and 22, and there is fusion of the BCR and ABL genes. And I think there's a picture of it coming up. But if you see Philadelphia chromosome, think CML. How does it present? So quite a lot are asymptomatic. You might have the constitutional symptoms that we discussed before, so the symptoms of pancytopenia, and some can present in blast crisis, as we said. So this shows the Philadelphia chromosome over here. So you can see that chromosome 9 and 22 have fused together, which predisposes you to CML. So that's CML. Moving on to CLL, so chronic lymphoblastic leukemia. CLL is a cancer of mature B cells. It's technically a subtype of non-Hodgkin's lymphoma, but we'll get onto that when we go over lymphoma. This is by far the most common type of leukemia, and it's common in the elderly. So buzzwords to know for exams. If there are smudge or smear cells present, it's CLL. Smudge and smear cells, they are lymphocytes which are particularly friable, and you can see them on a blood film. And there is also something called Richter's transformation. It's not that common, only occurs in about 5% of cases of CLL, but Richter's transformation, around 5% will transform into high-grade non-Hodgkin's lymphomas. And it may be indicated by the presence of B symptoms. And again, we'll talk about B symptoms when we discuss lymphoma. So presentation of CLL, it's almost the same as CML. So asymptomatic, constitutional symptoms, things like lethargy, bleeding, recurrent infections, etc. Again, I didn't go too much into management because I don't think it's that relevant, but essentially for CML, you can give a drug called imatinib. This is effective against the Philadelphia chromosome. For CLL as well, there are different chemotherapy options and antibody therapy. You can also give steroids and stem cell transplants, and there are some new drugs coming through continuously. Okay, so how do you investigate leukemia? So important things to do are FBC, to give you an idea of the blood counts. A blood film is really important because it can identify things like blasts and aborods, which we discussed, and a coagulation screen as well to see if their clotting is affected. But does anyone know the gold standard investigation for leukemia to give you a diagnosis? If you pop it in the chat. Is anyone brave enough to unmute themselves? Oh, I can't hear you, Catherine. I think you're muted.
I forgot, sorry. Bone marrow biopsy.
Yeah, that's perfect. Bone marrow biopsy is the gold standard investigation. And there are different aspects of it, which I don't think are very important for exams, but it's essentially sampling the bone, testing it for genetic abnormalities and specific proteins. You can also do an LP if there's CNS disease suspected. So that's just an example of the bone marrow biopsy. It's quite painful for patients, so it's not a very pleasant experience. And it's normally done along the iliac crest with the patient on their side like that. Okay. So that's investigating leukemia. I said we touch on myelodysplastic syndrome. Quite a scary word, myelodysplastic syndrome. You might be thinking, what is it? It's also known as myelodysplasia. It might be secondary to chemotherapy, and it's almost exclusively in patients over the age of 60. The way to think of myelodysplastic syndrome is essentially a bit like a pre-leukemia. So abnormal blood counts, you may have all three lines affected, but most commonly anemia. And essentially it's pre-malignant. So you might have early AML, and myelodysplastic syndrome is defined when there are less than 20% of blasts in the blood. When it becomes more than 20%, it's AML. Okay, so you might want to consider this in patients with abnormal blood counts with no obvious explanation. So everything else in their blood suggests that there's no other abnormality. There's a wide spectrum of disease, and severity and treatment varies depending on this. A lot of patients end up dying before this transforms to AML, so treatment can be controversial. But if there's anything to take home from MDS, remember it as a kind of a pre-AML, and the 20% cutoff. So if it's less than 20% blast, it's MDS. If it's more than 20%, it's acute myeloid leukemia. So that's MDS. Myeloproliferative disorders. Myeloproliferative disorders are an overproduction of mature blood cells. So it's a disease of the elderly again. And the type of disorder depends on what kind of cells are being overproduced. So red blood cells, if it's red blood cells that are being overproduced, the condition that you get is polycythemia vera. I'm not going to go into the details of these because it's kind of beyond the scope of this talk. But if you have a read up on them to make sure you're ready for the exams. So polycythemia vera describes increased red blood cells. If it is white blood cells, it is CML, because remember we discussed that chronic leukemias are a malignancy of mature blood cells. So overproduction of these is CML. And lastly, platelets. So overproduction of platelets is called essential thrombocytosis. Thrombocytosis is just a term to describe a high level of platelets. And there are various different causes for this, but essential thrombocytosis is when there's no apparent cause, and it's a myeloproliferative disorder. Okay, so that kind of wraps up leukemias. So we'll move on to myeloma. So what is myeloma? So myeloma is a malignancy of plasma cells. So if we look again at our flow chart here, if you follow it down to the plasma cells here, the plasma cells are what produce antibodies. So this is a cancer of the plasma cells. What it means is, it's the second most common hematological malignancy. The peak incidence is in patients aged 60 to 70 years old. And it's a spectrum of disease, that's important to remember. So you can have a solitary myeloma. This is when it's a solitary plasmacytoma. They don't have myeloma cells in the bone marrow or throughout the body. Instead, they have a tumor composed of plasma cells that is restricted to a single area of the body. And there's also something called MGUS. I think this would be quite harsh if it came up in exams, but it is always a possibility. So this is monoclonal gammopathy of unknown significance. All this is, it just describes an increase in one type of immunoglobulin. So around 10% of MGUS patients will develop myeloma over 10 years. But it's a spectrum of disease. So the more types of immunoglobulin that are affected, the more severe the myeloma is going to be. So the way to remember the features of myeloma is the acronym CRAB. So I think I saw this on Past Medicine. They've got some good resources on there. So C is for calcium. Calcium is raised. R is for renal failure. A for anemia. And B for bone lesions, so lytic lesions of the bone. That's the best way to remember the features. But to just go into a bit more detail. So the features are a result of the wrong balance of immunoglobulins. So various things that can happen with myeloma. You get hyperviscosity. So this predisposes you to things like DVTs and strokes and thrombosis. It can cause renal failure in around 20 to 40%. So the reason for this is if you've taken you back to your first year of your antibodies. So you've got your heavy chains and your light chains. What causes the renal failure is the light chains get deposited within the tubules of the kidney. Anemia anemia can be caused by bone marrow crowding. So there's decreased red blood cell production, and you can also get recurrent infections. This is because there's decreased production of normal antibodies and immunoglobulins. Bone pain is a typical feature. Usually in exams, they say an elderly patient with back pain, and then using other key investigations in the blood, such as hypercalcemia or renal failure, you can put 2 and 2 together. You can also get hepatomegaly as well. So the reason that these patients get hypercalcemia is there's increased osteoclastic resorption of the bone caused by local cytokines, which is released by the myeloma cells. Okay, so investigating myeloma. So you'd want to start by doing an FBC, U&Es, bone profile, and blood film. So in terms of investigating myeloma, again, there are a few buzzwords to learn for exams. Does anyone want to put anything in the chat? What certain investigations they want to do for myeloma?
So someone said plasma electrophoresis.
Okay, that's brilliant. So plasma electrophoresis is exactly what you do. This can show raised IgA or IgG proteins in the serum. Alternatively, you can do a urinary Bence-Jones protein. This has come up in a question in one of our exams in the past, so I would remember that, the urinary Bence-Jones protein. But again, the definitive investigation is a bone marrow biopsy. You can also do a whole body MRI to survey the skeleton for bone lesions. And does anyone know what sign this is, which you can see on the X-ray of a skull?
So someone said lytic lesions and,
Yes.
and raindrop skulls, what someone else has said.
That's perfect. So yeah, that's correct. These are lytic lesions all around the skull, and that is known as raindrop skull. Well done, whoever said that. There's also a similar appearance on a head X-ray called pepper pot skull, and that's associated with primary hyperparathyroidism. It's very difficult to tell the difference between the two. Looking at an X-ray, so you need some clinical context to differentiate between them. So management of myeloma, again, don't think it's that important at our level, but I'll go over it quickly. So the aims of management are to control symptoms and reduce complications, and obviously prolong survival. It's got a chronic relapsing course, so it can be quite difficult to treat. You want to give induction with combination chemotherapy. You can give autologous stem cell transplant in the first remission. But a lot of it is managing complications as they arise in the disease. So it can be quite painful, especially the bone lesions. So you'd want to give analgesia, and you'd work your way up the WHO ladder. So starting with simple analgesics like paracetamol and NSAIDs, and then moving up to opiates. For pathological fractures, you can give zoledronic acid, which is a bisphosphonate. For infection control, the annual influenza vaccine is given to all patients, and you can also give IV immunoglobulin to boost the patient's immunity. VTE prophylaxis is important because we said it can predispose you to thrombosis, and fatigue can be a varying cause. So treat the underlying cause, and you can consider giving erythropoietin injections as well if the red blood cell levels are low. Prognosis, after about a year, it's around 77% survival rate, and after 5 years, is 47%. So it's not the worst cancer to have, but it's definitely not the best either. So that's multiple myeloma. Moving on now to lymphoma. So lymphoma can be split into 2 different types. Does anyone want to write down in the chat what they are?
People have said Hodgkin and non-Hodgkin.
Yeah, perfect. So Hodgkin's and non-Hodgkin's. So we'll go over these now. So starting with Hodgkin's lymphoma, it's a relatively uncommon cancer. It's a malignant proliferation of lymphocytes characterized by the presence of Reed-Sternberg cells. I definitely remember this for exams. They like to ask questions about lymphomas. So Reed-Sternberg cells is a buzzword for Hodgkin's lymphoma, and that's the main way that it's differentiated from non-Hodgkin's lymphoma. I've also put in brackets there Alzey's inclusions. So Reed-Sternberg cell is the American term, and Alzey's inclusions is the British one. But I think in an exam question, they're more likely to go for Reed-Sternberg cells. And there's a picture of it on the right there. It has a bimodal age distribution. So it occurs in patients aged 15 to 30 and also over the age of 65. There are lots of different subtypes, and I don't think it's very important to know about all of them, but if you're going to learn one, just know that the most common type is nodular sclerosing, and it also has the best prognosis. It's also important to note that EBV, so Epstein-Barr virus, is linked to just under half of cases. So that's a big cause of Hodgkin's lymphoma. So features of Hodgkin's lymphoma. So you'll get asymptomatic lymphadenopathy, typically in the cervical region. And the way it's commonly described in textbooks and exam questions, a rubbery lymph node, which is painful after drinking alcohol. So if you see in a question, a patient has noticed a lump in their neck, they've had a few beers and reported that the lump has started to become painful, you'd think Hodgkin's lymphoma. You can get enormocytic anemia and lymphopenia in advanced disease. In 25% of patients, they get B symptoms. So B symptoms usually show that there's a bit of a worse prognosis. These are things like weight loss, night sweats, and something called Pell-Epstein fever. So Pell-Epstein fever, it's a high-grade fever that keeps rising and falling every 7 to 10 days. The fever rises abruptly, it stays high for about a week or so, and then falls close to normal abruptly again. And then it stays low for about a week. So it's up and down. And one other thing worth noting, LDH can be raised as well in Hodgkin's lymphoma. So that's Hodgkin's lymphoma. Moving on to non-Hodgkin's lymphoma. So this is the same. It's malignant proliferation of lymphocytes which accumulate in the lymph nodes and organs, but this time without the presence of Reed-Sternberg cells. In contrast to Hodgkin's lymphoma, it's a lot more common. It's the 6th most common cancer in the UK. This can affect the B cells or the T cells, much more common in B cells. And if it affects the T cells, it carries a worse prognosis as well. It can be classified as high grade or low grade. And there are some different types there as well, which you can read. So diffuse large B cell lymphoma is the most common. There's also follicular mantle cell, small lymphocytic lymphoma, which is CLL, and Burkitt's lymphoma. I'm just going to touch on Burkitt's lymphoma because it's you can definitely get examined on Burkitt's lymphoma. So this is a high-grade non-Hodgkin's lymphoma. There are 2 different types. There's the endemic form, which tends to occur in African people. It typically involves the maxilla or the mandible, as you can see in the patient there. There's also the sporadic type, of which ileocecal tumours are the most common form, and there's a link with HIV there. EBV is also strongly associated with Burkitt's lymphoma, and a buzzword for Burkitt's lymphoma, if you see that on histology, there is a starry sky appearance, then it's Burkitt's lymphoma. So this is how they describe a starry sky appearance. I'll be honest, I'm not sure I can really see a starry sky there, but I'll leave that to your imagination. So features of non-Hodgkin's lymphoma. So again, like Hodgkin's lymphoma, a painless lymphadenopathy. There's no relation to alcohol this time around. Your normal constitutional symptoms. Your B symptoms are more common in non-Hodgkin's lymphoma than Hodgkin's lymphoma, and they tend to present earlier. You also get extranodal disease. So it can affect the gastric system, the bone marrow, the lungs, the central nervous system, and the skin. So that's something to be aware of. Does anyone know how we stage lymphomas? What staging system is used? Pop down in the chat.
So it looks like people in the chat know, but they can't remember the name of it.
Okay, fine. So it's called the Ann Arbor staging system. This is used for all types of lymphomas, and there are 4 different stages. So stage 1 is when there's a single lymph node region involved. Stage 2 is when there are 2 or more regions on the same side of the diaphragm. Stage 3 is involvement of regions on both sides of the diaphragm. And stage 4 is involvement of extranodal sites. Whether or not you need to know the individual stages, I don't know. I mean, it may be worth learning, but as long as you know the name Ann Arbor staging system for lymphomas, you should be fine. And the way it's staged is using a CT of the thorax, abdomen, and pelvis. Okay. So again, this is things to pick up in the preamble of exam questions. So there are some associations with lymphomas. So we mentioned that EBV is linked to Burkitt's and Hodgkin's. HIV-1 is linked to high-grade B-cell lymphomas. H. pylori is linked to MALT lymphomas, which are found in the GI system, GI tract. And there's also a virus called HTLV-1, which can predispose you to adult T-cell lymphoma. In terms of investigating lymphoma, so the gold standard is an excisional node biopsy. You can see in the picture there, there's a big lymph node which is about to be removed, and then it'll go off to the path lab. CT tap for staging, as we discussed before. Bone marrow biopsy is important. HIV testing, FBC and blood film. ESR and LDH are useful prognosticators, so higher they are, the worse the prognosis is going to be. And lastly, a PET CT for Hodgkin's lymphoma and high-grade non-Hodgkin's lymphoma. So management of lymphomas, it's very similar for all of them, but Hodgkin's lymphoma, you'd use chemotherapy plus minus radiotherapy. And then non-Hodgkin's lymphoma depends on whether it's high-grade or low-grade. So if it's high-grade, you can use a combination of chemotherapy with or without radiotherapy. And low grade will be guided, that the treatment will be guided by the symptoms and the disease extent. All treatment will be an MDT led management, and there'll be a big team deciding which selected patients are appropriate for chemo, radiotherapy, palliative care, etc. Okay, so that kind of covers what you need to know for exams regarding the hematological malignancies. Those are the main important ones, which I think they could ask you on. So I'm just going to talk a little bit about anemia. Like I said at the start, I'm not going to go into great depths about it because that's a whole different talk in itself. And I don't think I'll have time for that. So we'll just quickly go over the different types of anemia and how they can be categorized. So when you see that a patient has a low HB on their bloods, the next thing you want to look at, or the next thing that I certainly look at, is the MCV. So that's the mean corpuscular volume. And there are three different outcomes of this. So if the MCV is low, then it's a microcytic anemia. If it's normal, then it's a normocytic anemia. And if it's high, it's a macrocytic anemia. So the commonest cause of microcytic anemia is iron deficiency anemia. There's also thalassemia, anemia of chronic disease, sideroblastic anemia, and lead poisoning. But certainly iron deficiency anemia comes up in exams quite a lot. Where it might come up in the context of a 2-week referral for bowel cancer. So if you have a look at the 2-week referral rules a bit later on, you'll see that iron deficiency anemia is one of the criteria for referring, and particularly Liverpool love asking questions about 2-week weights. So I'd have a look at iron deficiency anemia. Normocytic anemia, so anemia of chronic disease, acute blood loss. It can be a mixed picture of microcytic and macrocytic, aplastic anemias and hemolytic anemias. And then macrocytic, so the most common of which is B12 and folate deficiency. So these are megaloblastic anemias, meaning that the red blood cells are really big in size. Other causes: alcohol, liver disease, myelodysplastic syndrome, pregnancy, and hypothyroidism. So I just take the time to just learn these and just make sure that you have them down. And last bit on anemias, so I'll just quickly rattle through a few. So iron deficiency anemia, so obviously you'll have a low hemoglobin because that's the definition of anemia. A low MCV, so that means it's microcytic. They're iron deficient, so they'll have a low serum iron. They'll have a high TIBC. So TIBC is what the iron binds to. So if there's not a lot of iron floating around to bind to the TIBC, then the amount of TIBC available for binding is going to be high. And a buzzword for iron deficiency anemia are target cells, or pencil, poikilocytes. Yeah. Other different types of anemia, just quick points. So sideroblastic anemia, they're red cells which fail to form heme. and it can be congenital or acquired. Aplastic anemia, this is characterized by a pancytopenia and hyperplastic bone marrow, and this may be the presenting feature of acute leukemias. You can also get pernicious anemia. So pernicious anemia is an autoimmune disease. Intrinsic factor is a factor in the stomach, which helps absorb B12. So it binds to B12, allowing it to be absorbed in the intestines. So pernicious anemia is a disease where you form antibodies against the intrinsic factor, so you're not able to absorb B12, which can cause a macrocytic anemia. And then some other ones are hemolytic anemia and sickle cell anemia. But again, they're quite, there's quite a lot to go into with those, so I won't touch on those today. So those are the main points from the talk. So I've got 5 questions here, which you can all have a go at. You can either put the answers in the chat, or if you'd rather not, just write it down. I'll give you a bit of time to go over them. So question number 1. A 3-year-old girl presents with 8 weeks of lethargy and lack of energy. Some bloods are done and the investigations are shown below. So hemoglobin of 83, MCV of 79, white cell count of 21.5, and platelets of 65. The normal values are shown in the brackets. So which is the most likely diagnosis? I'll give you about half a minute to have a stab at that.
So we've got a few answers coming back in the chat. It looks like everyone's thinking it's A.
Okay, brilliant. A is the correct answer. This is because the patient's age, so they're 3 years old, and their hemoglobin is low, so meaning that they're anemic. Their platelets are low, so they've got thrombocytopenia, and their white cell counts are high, but they're likely to be immature cells, so they won't be functioning well and helping the patient's immune system. So for that reason, it's ALL. Really, of those options, the only 2 which it could be are ALL or AML, but given the patient's age, ALL is far more likely. Okay, brilliant. Question number 2. So our rods are present in which type of malignancy?
So again, we've got everyone sort of deciding on D.
Yeah, fab. That is the correct answer. D. Our rods are pathognomic of AML, so that's correct. So moving on to the 3rd question. An 18-year-old student presents to your GP practice after presenting to see you a week ago with a supraclavicular neck lump. The last consultation reads that she had also been feeling unwell with night sweats and loss of appetite. On examination, the neck lump was rubbery and non-tender. A biopsy has been taken and she has come for the results. The report shows Reed-Sternberg cells. What is the most likely diagnosis?
So we've got a few people in the chat saying B.
Fantastic. B is the correct answer. So the main things which point towards that are quite a young patient, supraclavicular neck lump, presence of B symptoms with the night sweats and loss of appetite, and it's described as rubbery, which is often how they describe the neck lumps in lymphomas. And Reed-Sternberg cells, of course, is the main differentiator between options A and B. Fab. Okay. So this is straight off Pass Med. So a 63-year-old man presents to his GP with a 3-month history of feeling tired all the time and getting out of breath when walking more easily than he used to. He has also reported feeling low in mood over the past month, with less interest in pursuing his usual hobbies. When asked about recent weight loss, although he hasn't weighed himself, he does feel as though his waist size has decreased as he has needed to tighten his belt more recently. His GP decides to arrange some routine blood tests which show the following. So there are the bloods, and on the right-hand side, the reference ranges. Which further investigation is most useful in investigating the likely underlying cause of his symptoms?
Everyone in the chat's in agreement with E as their answer.
Brilliant. E is the correct answer. So fantastic, you're all able to identify this as myeloma. So the combination of hypercalcemia and weight loss, that should raise suspicion of lytic bone metastases. The presence of renal failure and anemia are most suggestive of myeloma. So therefore the serum protein electrophoresis or urinary Bence-Jones protein should be the investigation of choice. ESR being elevated is suggested of myeloma, although it wouldn't be diagnostic or help to rule out a diagnosis of myeloma. And then the same is true for the radioisotope scan, which would likely show lytic lesions, but it might not indicate the cause. A CT thorax, abdomen, pelvis to look for malignancy would be indicated if the protein electrophoresis was negative, if it ruled out myeloma. And lastly, the PSA level, it wouldn't be helpful as prostate cancer, usually it doesn't have an elevated PSA. And when it metastasizes to bone, it causes sclerotic lesions, which would not produce the results that the patient has in his bloods. Okay, and final question, nice short one. So a Philadelphia chromosome is a translocation of which of the following?
We've got an answer of C.
C is the correct answer. Fantastic. There we go. Okay, so yeah, that's the end of the talk. I hope that you'll find it useful and can take something from it for your exams. I say key take-home points are look out for the buzzwords because they like to use them in exams a lot. And I think, so this is being recorded so you can watch it on the GPSOC YouTube channel, and feel free to go over it in your own time as well.